Well, good afternoon. I'm Allison Foster, the Executive Secretary for Delta Omega, the Public Health Honorary Society. As we celebrate Delta Omega's 100-year anniversary, I'd like to welcome you to today's presentation. It's the second in a series looking back at public health over the past 10 decades. Today's presenter is Elizabeth Clayton, Assistant Professor in the Department of Social and Behavioral Sciences at West Virginia University School of Public Health. Thank you, Elizabeth. We look forward to hearing your presentation.
Thank you so much. Good afternoon, everyone. I'm really excited to be here today. I'm going to share my screen and just let me know if you can see it okay. I'm very excited to talk about making public health a priority in the Great Depression and some notable public health achievements and challenges in the 1930s and how we can use them as lessons for today as well. As Allison mentioned, I am the faculty advisor of the Gamma Mu chapter. So I just want to briefly touch on some of the things that we do and who we are before I get started. We were established in 2012, so a couple of years ago, and we have done a lot since then. Unlike some other chapters, we have a leadership team of primarily students, including undergraduates, masters, and PhD students, led by always a faculty advisor to help guide them through. We do a number of community service, scholarship, and outreach events throughout each year. And some notable accomplishments that I'd just like to note this year, we've created a fully functioning career closet for students so that if they do not have professional clothes to wear to interviews, presentations, posters, they have a very easy access to this fully functioning career closet that's based on donations. We also have multiple in-person and virtual service events, several per semester. We have hosted a research roundtable with faculty to help connect students to faculty who might have similar research interests. And then we have an alumni roundtable event, and we are hosting another one this spring to try to connect our current students to individuals in careers that might be helpful for their MPH practicums, or even future careers once they graduate from us. All right, and so this is just the layout of today and what I'm going to talk about. I'm going to first go into some public health concerns of the 1930s. What were the major concerns of what was happening? I'm going to discuss epigenetics because it's a critical component that we must consider when we look at the Great Depression. I'll discuss the New Deal and how that helped to improve health and to mitigate poor health outcomes. I'll discuss the attempt for national health insurance in the 1930s. And then, of course, we're going to note the Tuskegee syphilis study and how that set the stage for a burgeoning change in research ethics over the next few decades. And then I want to connect all of these lessons because history is most helpful to us when we can learn from it, and when we can use it to inform what we do today. And that's why I love history of public health and history of medicine, is because it has so much relevance to what we do today, even if something happened so many years ago. So first, I want to talk about some Depression-era public health concerns, highlighting some of the major issues that were happening in this time. So there was a public health crisis, and it was primarily crisis emanating from social determinants of health. We know that by 1933, about 25% of the workforce was out of work. 25 million people were unemployed at that time. And that had impacts not only for the individuals, but for their family and for communities. We had a lot of rising poverty in rural and urban areas, some declines in sanitation and hygiene due to limited resources and finances, and an increased rate of death by suicide due to the challenges of the time that were really beyond a lot of individuals' control or ability to change. There were massive changes both in our country and worldwide. And we saw migrations from rural areas to urban areas for work. So there was a lot of upheaval and change in this time for families and for communities, which changed the infrastructure of how people network, social support, and really having a stable home where people could learn, work, and grow. The Dust Bowl era migration also happened, where failed farms, those families moved to California, out of a farm environment and into something that they were less accustomed to. All of these things created lasting effects, with poor health, greater risk of disability, and higher mortality due to heart disease and diabetes. So I mentioned that 25% of the workforce was unemployed at that height in 1933. Just to give you a reference, that's compared to about 3.7% unemployment today. And so this was a situation where a great majority of a great number of the workforce were out of work. And that changed the circumstances that they lived in drastically. So when we're thinking about this time, there were a lot of challenges. So the goals of the public health service at that time were to really focus on improving sanitation, to do a lot of investigation into chronic and infectious diseases and try to mitigate them, and to focus on health education to promote health behaviors, even within a very impoverished environment. By 1931, we had 599 county health departments. These were growing during this time, and they provided health services to about a fifth of the US population. There was also a notable act of 1938, the Food, Drug, and Cosmetic Act, which tried to protect the public from dangerous and unregulated drugs, and tried to provide regulations for food to keep the public safe, especially from infectious diseases carried through food. So as I mentioned, when we think about the 1930s, we also have to think about the lasting effects from public health concerns at that time. We had a lot of public health involvement at this time to mitigate health problems and to promote health through those county health departments, through sanitation, investigation, and education. But there were a lot of changes that happened because of the environment that individuals lived in. So we know that stress changes you and future generations. Those individuals who are exposed in utero to the stress during the 1930s, including food insecurity, this was associated with an accelerated aging process after age 75. So those individuals went through an aging process much more rapidly than they might have had they not had some of those environmental stressors. So epigenetics looks specifically at these interactions between gene and environment. Epigenetics wasn't understood at the time, but it was occurring, and these different patterns and the research from that time about how people's health changed due to those environmental stressors really helps us understand how to try to mitigate harm and how important our environment is for us. I want to just discuss the fetal programming hypothesis when we talk about epigenetics. So this hypothesis looks at how fetal responses to an intrauterine environment may be origins of chronic diseases that happen much later in life. So this is important because it shows that in issues that occurred in the 1930s weren't constrained to public health problems in the 1930s. They may have related to chronic diseases, morbidity and mortality much further down the line. So some ideas that are important when we think about this hypothesis is that there's a persistency. So the conditions that resulted from this fetal environment will continue to exist even after that fetus is no longer in that environment. There's latency too, which effects may show up later in life in the form of chronic diseases. And this idea of fetal programming, where this environment in utero can help turn genetic switches on and off. So it can modify the genes by exposure to stressors, by exposure to malnutrition in utero. All those things can have an impact on someone's genetic structure and increase their risk for chronic diseases. So some of the epigenetics effects we saw from the Great Depression, from the problems in the 1930s, those stressors and financial strain on parents during the Depression was associated with children's later poor health. We know that offspring from Depression era parents, specifically in areas with larger reductions in wages, those individuals also earn less throughout their careers. And those who were exposed in utero to those stressors, as opposed to individuals who were already children, school-age children or adolescents in the Depression, those exposed in utero had a greater impact on reductions in wages later in their life. So we see that the issues that occurred in the 1930s related to this impoverished environment with and financial strain and unemployment lasted, and it affected individuals' health long after. So I want to discuss now the New Deal and how that helped to improve health and to mitigate harm done to health during this time. I mentioned those epigenetic effects, and I want to talk about how the New Deal really helped to change the likelihood of better health for these individuals. So there were a total of 18,371 New Deal sites across the country. They weren't just clustered in one area or in urban areas. They were across the country in both urban and rural areas. Notably, there's actually one pretty near to where West Virginia University is in Morgantown, West Virginia, and that's Arthurdale. And Arthurdale was one of the first New Deal communities. It was a homestead community. Throughout the New Deal history, there would be a total of 99 homestead communities, but Arthurdale was the first, and it was visited by Eleanor Roosevelt quite often. And the idea was to create a sort of self-sufficient community that would farm and also have a number of different job opportunities, and individuals would live where they worked as well. And so it was very novel at that time, and it expanded to 99 others. So probably wherever you live, there is a New Deal site somewhere near you. And there is a map here that helps to show where all these New Deal projects were. I think this is a really valuable map to see, just to see the pervasiveness of these programs and how widespread it was across the whole country. These were projects that were put in place to help with employment, to help with creating new things for the nation. But they were public health efforts as well, because they put people back to work, because they gave people hope and purpose, and changed the communities that they existed in. And so if you follow that link, you can go to an interactive map that shows you all the New Deal sites and what those were. I really like this quote that just sort of explains the reach of the New Deal, how broad it was. So it says, if you were to come to this country and you were at LaGuardia Airport, you would be at an airport that Roosevelt and the New Deal had built. And then if you went over the Triborough Bridge and through the Lincoln Tunnel and continued west across the country on the Blue Ridge Parkway, on the Skyline Drive, took Chicago subway, went all the way across the Great Dams of Bonneville and Grand Coulee, all of this was done under Roosevelt and the New Deal. And so just thinking about the sheer expanse of these projects across the country, trying to put people back to work, trying to change the environment that people lived in during this Depression. These programs really changed public health. It changed people's health prospects. We know that unemployment relief programs alone accounted for 2.5% reduction in mortality for individuals. There were gaps within these unemployment relief programs, and we saw that the mortality reductions, mortality was lower in white families than other races and ethnicities. So the majority of the reductions were in white families as opposed to other races and ethnicities. And so there were gaps within these unemployment relief programs, but they overall accounted for 2.5% reduction in mortality. We also know, based on epigenetics, that the impact in utero for children of the Depression was also ameliorated by these social programs. So it helped to reduce the impact on fetuses in utero. I want to discuss the attempt for national health insurance to just sort of describe what was going on at the time, and then also to connect to today as well. So there were a lot of rising healthcare costs in the 1920s that burgeoned into the 1930s. And there were a number of reasons for this, including that the cost rose due to a higher demand on hospitals. This was because people had less room to care for sick family members, and it became less accepted to care for sick family members in the home. It became the accepted standard that individuals who were sick went to the hospital. And so that increased hospital costs and increased the burden on families for those hospital costs. We also had a lot of advances in medical technology and stricter criteria for licensing for doctors and accreditation for hospitals. And all of those related to costs that then were put to the individuals. By 1929, the average family medical expenses were about $103 or 5% of their annual income. And so this was an environment where we saw rising healthcare costs, which we can imagine is pretty similar to what we see now in increasing healthcare costs, even now that place a lot of burden on individuals to pay. To just go through a timeline of what occurred to help lead up to this national health bill that was proposed. There was a Committee on Economic Security in 1934, and this was to address retirement, unemployment, and insurance at the time to figure out how we could best safeguard individuals who were experiencing the effects of the Great Depression. The Social Security Act was put into place in 1935 that was specifically to safeguard retirees, and it also had grants to encourage maternal and child health. In 1936, we saw the National Health Survey, which is the forerunner of the National Health Interview Survey today, to understand what health problems people were having across the country and to connect national level data on this. In 1938, there was a National Health Conference and convened in Washington, D.C. to discuss this proposal for having a national health insurance. And in 1939, this national health bill was introduced by Senator Wagner with recommendations from that conference. However, the proposal died in committee. And I just want to discuss some of the reasons that occurred as well. So there was some fear from the medical profession at that time that this would lead to control of the medical profession by the government and would set their costs rather than the medical professionals being able to set their own costs. There was also public concern that public health professionals might be overstepping what should be in a physician's purview. And there was this tension between federal and local needs. So there was a public belief that federal laws and responses might not be able to fully address local needs. And then the idea that public health didn't need additional funding at that time because a lot of individuals saw declines in mortality from 1900 to 1930. And so the belief was that there was enough funding in the public health realm at that time. So instead of that national health insurance, voluntary insurance became widespread at that time, and those commercial plans proliferated and created a market that continued to grow into the 1940s and today. The commercial plans primarily focused originally on ensuring young, healthy, and employed workers to try to mitigate cost to the system. And so these changes occurred in an environment where, you know, national health insurance was considered, but I think it's important to understand the barriers to that at the time to understand, you know, where we are in terms of health insurance today and the barriers that we still see today. We can't talk about the 1930s without talking about Tuskegee and Tuskegee syphilis experiment. And this is important because although we cannot change what happened, we can understand and learn from this experience and try to ensure that our research ethics are solid going forward. And so I think it's something that we always have to talk about and consider. So I like this quote from President Bill Clinton in 1997 in his apology to the Tuskegee syphilis families and individuals who were still alive from that study. And it says, no power on earth can give you back the lives lost, the pain suffered, the years of internal torment and anguish. What was done cannot be undone. And I think that's critical to note, that what was done can't be undone, but we have an obligation to learn from this. We know that it began in 1932 as a natural history or untreated history of syphilis. It was involved 600 Black men, 399 with syphilis and 201 without. It was started by the U.S. Public Health Service. These individuals were told they were being treated for bad blood, which was a colloquially used term that could cover anything from syphilis to fatigue. And so it wasn't completely clear what they were being treated for. These individuals did not consent to participate, and no treatment was occurring during the time. They were given free medical exams, free meals, and burial insurance as for participation. A notable thing too is that penicillin was discovered as a cure for syphilis in the mid-1940s. However, it was not offered to the men. So this study continued until 1972, when an AP News report announced it, and following that, an advisory panel shut it down. Both of these are from the National Archives, a picture of men from the Tuskegee syphilis study, as well as a memorandum from Dr. Merlin Duval, formally ceasing the Tuskegee syphilis experiment. So I want to take all of this context, the 1930s, both the challenges and the progress that was made in how we addressed health and how we tried to ameliorate health concerns during this time, and shape it into some lessons that can still be relevant to our lives today. So some aspects that are sort of critical and came across in all of these different aspects of the 1930s were that there's the social determinants of health and how our holistic environment matters, reform programs and how these holistic programs can mitigate mortality and morbidity, especially in terms of crisis. That national health insurance had a chance at the time, but we can see a little bit of the context of barriers that occurred and why that occurred and how that has changed and shaped the landscape of our health insurance today. And then also talking about research ethics and ethics in our public health care. These standards are critical to be able to prevent harm. So thinking about social determinants of health, from the experiences of the Great Depression and those effects that I mentioned on epigenetics, we can see clearly that our environment matters. We know that social and political forces can affect individual health at a great level, and these can have lasting and generational consequences. So our public health efforts today can really impact public health in the future. We need to think about how public health can consider people in society holistically, and being in social and behavioral sciences, social determinants of health is something that I think about constantly. This is important to know how we can shape public health and ensure good health. And we also can note that the economic recession of the 2008 and COVID will likely have lasting consequences to health, because we've seen how those in utero stressors or early life stressors can change genetics and can change health and risk for chronic disease later on in life. The reform programs of the New Deal really helped to mitigate harm. We do see these echoes today. These are still being used today in different forms, including relief programs during that 2008 recession, COVID relief checks, as well as additional support payments for parents. And national relief and reform packages programs can continue to play a vital role in times of crisis and poor health in our country. Health insurance continues to be something that we struggle with today. In the face of rising healthcare costs and economic depressions, the attempt was made to build a national health insurance. The issue of insurance still remains a challenge, And with continuously increasing healthcare costs, new solutions are warranted, and it's important for us to look at our history to help us understand, maybe how to address some of the barriers that we faced then and we face now. And then in terms of ethics, the ethical transgressions of Tuskegee led to strict ethical guidelines and research that are still followed today. So in 1974, there was a National Commission for the Protection of Human Subjects and of Biomedical and Behavioral Research. And this is when ethical principles of research conduct were created. Voluntary informed consent, which was something that was not included in Tuskegee at all, was made mandatory in all studies of the Department of Health, Education, and Welfare in 1974 as well. And then in 1979, that well-known Belmont report talked about the principles of respect for persons, beneficence, and justice. And I just want to bring this all together to talk about how we can understand our history going forward. And so I like this quote to wrap it up. In history, a great volume is unrolled for instruction, drawing the materials of future wisdom from the past errors and infirmities of mankind. And so just this idea of, the challenges as well as the successes we had in the 1930s can be helpful even for the challenges that we face today. I will happily take questions now, if anyone has any questions.
All right, well, let me check. Thank you, Elizabeth. That was terrific and a great overview of the 1930s. Let me see if there are any questions. So there's one question asking a little more about the national health insurance. I think this is very much on our mind right now, of why the health insurance system in the US works the way it is and the lessons that we may or may not have learned. So the question is, can you go a little more into detail about the major reasons why the national health insurance was blocked?
Absolutely. So, there was that issue, I think, especially around the idea that federal responses might not be able to address those local needs. So specifically thinking about the geography, the changes, the differences across our very vast country, there was this conception that there's no way that the federal government will be able to create an insurance plan that would work for all those disparate areas. And so that was one of the biggest issues, as well as pushback from the medical professionals wanting to regulate their fees and wanting to not have control by the government at that point. And so we also saw in the 1940s to just sort of carry that forward. When individuals came back from World War II, there were sometimes not a lot of benefits that could be added to employment. And so trying to get people back into the workforce, health insurance was then tied to employment for, one of the first times. And it became something that people were offered with their employment. And that's sort of how it stayed today. And so it was created basically to encourage people to get back into the workforce after World War II as an incentive to protect their health. And now we see that health insurance is always tied with employment, primarily tied with employment.
Right. Okay. So there's another question about epigenetics and how it affects, just a general question, how it affects future generations. And I just want to mention, just this morning I was reading the paper and there was an article about a study done by the American Psychology Foundation in 2000, which is before 9/11, before COVID. And they were saying that the stress levels of children were higher on average than kids that were in psychiatric care in the 1950s. I don't know the study, but it just kind of resonated when you were talking about the stressors and the impact and, what helped in the times and what do you think is going to happen for future generations now based on what we know about past stressors?
Absolutely. So epigenetics is very interesting to me, based on some of the research I do too. And so we know that genes and environment interact, and especially thinking about that fetal programming hypothesis, in utero, that environment, even outside, can transcend and change genetics based on nutrition, based on stress, and the hormones associated with stress. And all those things can go and actually modify the genes and how those genes are expressed. And it's sort of like either a light switch on off for the gene, or maybe like a dimmer switch on a light. And so it can change the degree to which it is expressed or whether it's expressed at all. And so it doesn't necessarily, and I think that's one of the hopeful things about epigenetics, is that it doesn't necessarily mean someone is going, just because they have a gene that could be associated with a chronic disease, doesn't mean they're going to. So this is really where our health promotion efforts come in. If we know individuals are at risk for certain chronic diseases or certain problems or public health issues based on the stressors that were going on at the time, we can try to encourage health promotion programs and healthy behaviors. Someone has genes that might make it more likely they are going to have diabetes. We can make sure that we're working on health promotion programs to provide healthy eating habits, to provide different and various ways for exercise, to create environments that are healthy for individuals to live in. And so I think there's a lot of hope with epigenetics too. I know it can seem very down and very determined, but there's still that plasticity in epigenetics. Just because that gene is expressed, it doesn't mean that you're going to necessarily have that disease.
All right, thank you. Okay, let's see. Next question. Do you expect that we would see the same rapid aging in children who are born in 2008 and 2021 and make it to 75 as you saw in the descendants of the Great Depression?
I think we're going to have some chronic implications. I think there is a likelihood of that increased aging, since that is what we saw from the Great Depression and the stressors. But, the economic recession of 2008 was different than the Great Depression in terms of it was a recession. There was definitely financial strain, stressors, unemployment, but we may see a mitigated effect because it was a recession as opposed to a depression. And then COVID was a very unusual time. And so I think it's hard to know exactly what those chronic effects are going to be. But I think there will be lasting consequences from that for the children during that time, as well as in utero changes later on.
All right, thank you. All right, next question. How did the New Deal programs in 1930 still have an impact today?
So I think that's really important to see that, a lot of them are still there and we can learn from the history. But additionally, we can see how those are still applicable now in terms of those COVID relief checks. It changed the way, it didn't drastically change people's ability and finances during that time, but provided a little bit of relief, which may have helped individuals, health, especially having separate stipend checks for parents at that time helped to address the childcare burden of the COVID time as well. And so I think, they're not going to be the same programs today, but it can help us learn from history to have a guideline of, if we have a crisis now or in the future, how might we best deal with it? How can we create programs that can help ameliorate what people are experiencing, including addressing their social and financial environment as much as their health itself.
Great. So there's a question about obesity in our population, that our obesity rates are so high, and the question is, how can public health build an effective framework to meet this challenge?
Yeah, so trying to create an effective framework for obesity, I think it's a very complicated issue. It has a lot to do with our environment. We know that we have an environment that does not help people to be healthy. And we know that there are a lot of risk factors for obesity, as well as genetic components that can make it really challenging for people to maintain their weight. There's a lot of ways that people try to go about fixing this crisis. But I think we need to start by looking at the risk factors and creating environments where people can be healthy, where the default is for people to be able to make healthy choices. And that's not quite where we are with society at this point. But yeah, it needs to be a concerted effort. Just, as an eating disorder researcher, I think about obesity prevention in a very eating disorder informed lens. So trying to address those risk factors without trying to stigmatize or shame the individuals who are experiencing obesity, since that stigma and shame is a pervasive issue that also contributes to emotional eating and interacts with obesity over time too.
So the next question is about Tuskegee. Actually, I found it really interesting when you were talking about Tuskegee. 2 or 3 years ago, maybe, we inducted Peter Buxton into the society as an honorary member. He was on the slide. I didn't talk about him by name, but he was basically the whistleblower for Tuskegee. He got so frustrated that he quit his job and tried for many, many years to get the attention of people that could help. And finally, I think he had a friend in the press and really brought all the attention to it. So it's just, I was thinking about that. We actually gave it to him while he was still with us, so he was aware. Yeah. So the question is, do you think that we have systems in place to adequately prevent anything even close to what happened before, or do we still have more to do to make sure that could never be repeated?
I like to think that all the safeguards we have in place, we have pretty rigorous processes for training in human subjects, for training in ethics and research, for even getting studies approved. I'm submitting IRBs now, and I know the process can be long and complicated, and sometimes that can be frustrating. But it's really important to know that those processes are there for a reason. So I think we do have a lot of checks in place because there are always a lot of eyes on every study that occurs. That doesn't mean something like that could never happen again, but I think we've put the safeguards in place to make it extremely unlikely that would happen again.
All right. So I think we've gotten through all the questions. If you all have any others.
I see a question about the sources readings for the statistics. I've got references here that I am happy to share. Hold on, it's not going. Oh, sorry. There are references, I can share those, and I can share specifically that reference on that those exposed in utero had poor health outcomes after 75. I think that's really interesting. So I'll definitely share that, okay?
There might be one more. Oh, great one. So back to Tuskegee study. So what can be done to gain back the trust of the African American community in public health studies and clinical trials?
I think that's a really hard question to answer. I think that distrust is there for a very good reason, not just for the Tuskegee syphilis study, but Henrietta Lacks and many other ways in which research and the medical profession and the scientific profession have not conducted research or medical practice in the ways they should, specifically targeting and hurting the Black community. And I think, that's going to take time. I don't think there's anything that can really repair that. I think that's going to take involving individuals from those community into research that impacts them. So it can be a really community-based approach so that they are aware of, what's going on and they can be involved in the research process. And I think being involved in that process more as it affects their health can be very helpful. But I think we need to just make sure that everyone is having a voice because we've prevented that for so long. And I think those are some of the legacies that we can learn from that.
Right. All right. Well, thank you, Dr. Clayton. Again, this was an absolutely fantastic presentation and very thoughtful, a lot for us to think about. She shared her contact information. If you have any further questions, please go ahead and reach out to her directly. We will post a recording of this on our website shortly. And we do hope that you all will join us on the rest of our presentations this year. The next one is on March 28th on wastewater infrastructure, which is a topic near and dear to my heart. So I'm looking forward to that one as well. And we hope to see you all soon. All right. Thank you. Bye-bye.
Wonderful. Thank you all. Thank you so much.